Hello and welcome to the Royal College of Pathologists Guideline Implementation webinar programme. My name is Peter Johnston and I'm the Vice President for Workforce and Corporate Engagement at the College. I'm delighted to be hosting this webinar today where we have leading experts and authors for the latest guidelines for the histopathological reporting of tumours of the central nervous system in adults to include the pituitary gland. The authors will be clarifying some aspects of the guideline and helping us to implement it in the form of practical tips and how we use it clinically. The authors are also here to answer your questions. I'm very pleased to be able to introduce the speakers today for the dataset on histopathological reporting of tumours of the central nervous system in adults. They are Professor Sebastian Brandner and Professor Federico Roncaroli. We also of the team have present Professor Maria Thom, Dr. Ash Merve and Dr. Simon Paine. Unfortunately, Professor Zane Jaunmuktane cannot be with us today. Before we start the webinar, I'd like to tell you that the webinar presentation will take about 15 minutes, then there'll be about 20 minutes thereafter for questions and answers. All the participants are muted, and so if you'd like to ask a question, please do so using the Q&A function at the bottom right-hand side of your Zoom screen. We will then marshal these questions and produce, hopefully, a more flowing way of dealing with the questions coming through. So without any further ado, I would like to hand over by welcoming our speakers and pass the presentation to Professor Sebastian Brandner. Sebastian.
Yeah. Good afternoon. Many thanks, Peter, for the kind introduction. I would like to give a presentation on the implementation of the CNS dataset, and we will just get the slides advanced. So here in this table, you can see the main changes for the previous dataset, as just explained in the narrative. On the left-hand side, the previous data set. On the right-hand side, the current data set. So the left-hand side, based on the 2016 classification, here, the current guidance on the 2021 classification. The previous guideline made some recommendation of archiving, and as explained, the current guideline has a much stronger emphasis because of the increasing role of whole genome sequencing, the secondary use for research, accessibility of diagnostic material through the Brain UK virtual biobank. In the previous guideline, there were much less citations of evidence level for these recommendations. And now in the current guideline, there's a very consistent citation of evidence levels wherever possible to give users a better idea as to how the evidence for our claims is underpinned. The previous guideline contained a printed pro forma, which was not adequate for word processing or LIMS integration, and this has now changed. The Appendix C is a table-based systematic pro forma, which is increasingly important because these data sets and the reporting pro formas become part of laboratory information management system, LIMS. The previous guideline had a COSD version 8 and ICCR 2018 data elements. The new one has the ICCR 2020, the PITNET, and the COSD version 8. The main changes and the alignment with international recommendations. So the previous guideline in 2020 was based because it was written as a basis of the 2016 WHO classification. But between 2016 and 2020, a lot of changes happened, and there were a lot of recommendations for molecular testing, which then made it into the 2021 WHO classification. And all these are called CMPAC now. There's consortium to inform molecular and practical approaches to CNS tumor taxonomy, not official WHO. But essentially, all these recommendations have then made it into the 2021 WHO classification, as well as into our data set. The current data set follows international recommendation. There are publications for gliomas and meningiomas, and the WHO classification is here. So we are not going to discuss the details of the individual tumor types. There are 180 or 190 tumor types, many of which are molecularly characterized. And this is the 2024 published ICCR dataset. And here are the 2021 and 2023 European Association of Neuro-Oncology recommendations, so EANO, so guideline for rational molecular testing of gliomas and other gliomatoid tumors, and the molecular diagnostic tools for the WHO classification. These are the most recent See Impact Now, so published just this year. They didn't make it into the guidelines, but many of our guidelines aspects contain information from these because we were partly co-authors on these recommendations. So this is molecular testing on meningiomas. This is a molecular risk parameters and recommendations for WHO grading of meningiomas, and the 2025 Neuro-Oncology Advances, recommendations of genome-wide DNA methylation profiling for CNS tumor diagnostics. This is particularly relevant because it very closely aligns to the data set that we are talking about here. Again, main changes from the previous data set. How do we approach molecular testing of CNS tumors? The previous guideline 2020 was fairly advanced at the time. It already anticipated the 2021 WHO classification. At that time, it was all much less complex. The yellow areas here, methylation arrays, they were a novelty at the time. So we made kind of a streamlined recommendation. This has now become a lot more complex. It's not possible to put a decision-making tree, but this is now a very large, detailed matrix. On one hand, you have here, these are the diagnosis of a proportion of the tumors, and here are the different test methods. This is all very nicely laid out in Appendix G of our current guideline. So these are next-generation sequencing methods, methylation array methods, and how to combine them to achieve the most accurate tumor diagnosis. With this, I would like to pass on to one of the co-authors, Federico Roncaroli, who will talk about PIT-NET and pituitary lesions.
Thank you, Sebastian. The field of pituitary pathology is way back the integration of molecular and pathological data. So we decided of recommending, and immunohistochemistry is the cornerstone of the classification. So we decided of recommending a wide panel to classify pituitary tumors. We can call them PIT-NET or adenomas. Of course, everybody has different financial pressures. People, in particular in the US, tend to be applying a reduced panel. The problem of a reduced panel, it tends to be confirmatory of the clinical phenotype. A patient is acromegalic, you do GH, you confirm it, but it doesn't actually identify and subclassify pituitary tumor as they are. The introduction of pituitary transcription factors has been quite game-changing. The classification board is not the conclusive way of stratifying these tumors. It's actually identifying a lot of entities with mixed phenotypes. The key point of the data set, one of the key points of the data set is the concept of null cell adenoma or PIT-NET against immunonegative. So we suggest of not using the terminology of null cell. When all the immunohistochemistry immunostains are negative, the first question is asking whether it is a neuroendocrine tumor. So we suggest doing chromograinin, synaptophysin, ICNM1. If we confirm it's a pituitary, primary pituitary, and is immunonegative, then one step for the classification is using methylation arrays. Pretty much all the cases that do not stain for transcription factors or hormones come back as a gonadotroph or corticotroph identity. So null cell effectively don't exist. If there are questions about being a primary tumor of adenophysial cells, then we treat the biopsy as any surgical pathology specimen. So we broaden the panel of antibodies. TTF1 will be the first option, and then cytokeratins, and then everything that helps define the tumor. Some of the stains that we put as a level 4 help identifying what are potentially aggressive tumors. P53 is losing momentum, but still helpful in corticotrophs. Sometimes they are subclonal. So you find 10% of the tumor with strong positivity, the rest is negative. When they recur, the positive clone becomes 50-70% and eventually become the predominant one. ATRX is always very helpful, same protocol and immunohistochemistry as we use for gliomas. Genetic analysis is very limited. We recommend of testing P53 using a glioma panel. There's no specific panel for pituitary in prolactinomas and corticotroph, particularly. And this new gene that has been identified about 4 years ago, which is a selectively mutated in prolactinoma, seems to be identifying as F3B1 a subgroup of non-responsive prolactinomas that tend to be macro, invasive, and frequently recurring. We, via the European Society of Endocrinology, we are reducing the relevance of GMT. Immuno may help, is not really predictive or response to temozolomide, and the molecular that we apply for gliomas does not apply for pituitary tumors because they primers don't pick up in pituitary the same relevant part of the CPG island. If you can move to the next, Sebastian. One really key point to the recommendations or the data set, which is a frequent question in a clinical setting, is how we define an aggressive pituitary tumor. So the key point is we are not in a position as pathologists to say the tumor is aggressive. I would really advise on not commenting, pushing the diagnosis too much, because that will put the patient in a radiotherapy or chemotherapy protocol, and often which is often unnecessary. The term aggressive will be further clarified by the European Society. The paper is coming out and is a multidisciplinary approach where we have to consider size, invasion, rapid growth, rate of growth, no response to treatment, so the refractory plus the pathology. When we report a case that looks like aggressive, we can apply a 5-tier system from the French group that was published a few years ago. Be careful when you mention the so-called tier system. It's not it's a grading system or a staging system, it's a scoring system. We are changing terminology, and that goes as a comment. And again, without really pushing towards saying this is a tumor that's going to metastasize or is going to recur. There are a few references, very recent references in an issue in brain pathology you may want to read, and they were quite extensive in explaining the criteria. Next. Thank you. So very few words on posterior pituitary tumors. There's been a change between CNF5 and ENDO5. ENDO5, the endocrine classification, are suggesting they're all variants of epitucytoma. As a neuropathologist working in the pituitary field, we don't think they are. They all have in common TTF1 expression, that's fine, but they have different behaviors and different molecular profiles. So we think the best way is defining them as TTF1 expressing the posterior pituitary and then suggesting features of pituitary, spinocerebellar, etc. on the ground of 4 or 5 immunostains. In practical terms, TTF1 is the priority, and then combining GFAP, EMA, S100, CDC, ST8, we should be able to define the subentities. It may happen they are hybrid phenotypes. They don't seem to impact on the outcome, so it just becomes a descriptive report. Suggestions from recent papers highlight that spinocerebellar might be slightly more aggressive. There's no really definitive evidence that mitotic count, K67, or morphological features are predictive or prognostic. I put a graph from Simone Schmidt paper in Active Neuropath 4 years ago, where the only real correlation with the outcome is a copy number variation assessed with methylation arrays. But again, they still need to validate this data. And again, as it applies for pituitary tumors, I would not, in a pathology report, suggest anything regarding any possible aggressive behavior. Thank you.
Thank you very much, Fede. So that brings us to the last slide, the summary slide. I would like to highlight the consequences of the systematic implementation of the data set, the benefits, but also the challenges. So one of the problems is that practically all CNS tumors, with a few exceptions, now require molecular testing. Probably in daily practice, one can fairly say about 50% of the CNS tumors require one or other type of molecular testing, even if it's only basic one. Obviously, this requirement to test for treatment or for diagnosis can delay and also can make the final diagnosis complex, in particular if iterative. So all pathologists are aware if molecular tests come a week, 2 or 3 weeks later, whenever a test comes through and there's additional evidence, a supplementary report is issued. So sometimes we end up with, usually we end up with 2-part reports, often also 3 and 4, sometimes 5 iterative reports. The delivery of the genetic testing in the UK in England is done through genome laboratory hubs. Some of these genome laboratory hubs have quite long turnaround times for next-generation sequencing and also for methylation arrays. There are variations across different GLHs, but we usually talk about weeks. And then, of course, there's also, and a part of this problem is that within the genomic laboratory hubs, there's obviously there are clinical scientists who have to read the sequencing results, and often there's limited capacity of workforce to report these increasing numbers of molecular tests, and of course also on the pathology side, consultant pathologists who have to integrate those test results into a final diagnosis. So the end-to-end can easily be 5 or 6 weeks if the tests are done iteratively. It is definitely a challenge to have molecular data systematically implemented in the laboratory information management system, in that there are literally hundreds of different outcomes. As a result, these results are, the molecular data are usually entered as free text, which makes the data analysis or data mining later on more complex. Also, another effect on our oncology, neuro-oncologists and also the patients. Often patients need to be multiply listed on the multidisciplinary team meetings. First time a week later for the diagnosis, but then also for the first molecular test, if it's unsuccessful again, sometimes 4 or 5 listings, which again it could be a significant burden for the clinical workforce. The benefit of the implementation of the more systematic molecular tests, a significant reduction of the immunohistochemical tests required. Very often we get away with 1 or 2 tests, sometimes 5. Very rarely we do more than 8 immunohistochemical tests on tumors, because before you get on with too many immunotests, they're more readily answered by the outcome of a molecular test. So these are the important stainings. Obviously, it's not exhaustive, but the most commonly used one: IDH, mutation-specific antibody, H3K27M, BRAF V600E, other mutation surrogates like INI1 and ATX, they are important. But these generic protein stains like NUN, GFRP, CD56, synaptophysin, vimentin, they have much less significance today compared to 10 years ago. And another huge benefit, these molecular tests, they aligned with the advancement of knowledge about these tumors, the tumor entities or tumor types, obviously have now minimized incorrect diagnosis. And that is the end of the presentation. Thank you very much. And this is now open for questions.
Thank you very much, Sebastian, and thank you, Federico, as well. We don't have any questions in yet, so just while we're waiting for questions to come in, well, one's just arrived. So thank you very much. There's an issue, which the question that's come in was one that I was going to raise with you, actually, is around turnaround times in molecular testing. It's about how do we think that the recommendations from the college fit with the real lived experience of the national landscape of molecular testing, given the vagaries of local availability of tests and the time they take and the clinical relevance that there is of these whilst the patient is still waiting. So I guess how do the recommendations help us deal with these real life clinical concerns?
I mean, in fairness, a majority of CNS tumors, such as high-grade glioma, specifically glioblastoma, oligodendrogliomas, meningiomas, and then obviously their metastases as well, and pituitary tumors, they can be readily diagnosed without advanced molecular testing. But if, for example, for glioblastoma, MGMT promoter methylation is required, this usually turned around in a week or 10 days. So that doesn't pose any particular problems in terms of patient management. When it then comes to the more complex tests, which are required for high-grade intrinsic tumors in young people, low-grade tumors in young people, problematic appearing meningiomas, then obviously the turnaround time for these tests is highly relevant. Methylation arrays, for example, quite a relevant test for the diagnosis of a large number of CNS tumors, can take anything between 7 days and 4 weeks, depending on the genome laboratory hub. So for the GLHs, the genome laboratory hubs, there are clear guidance and targets set by NHS England, who commissioned the service, the delivery of these tests to the GLHs, which stipulate that 21 days should be the limit of the test turnaround. So 90% in 21 days. We can see in many GLHs, this does not meet the reality. Often tests are very complex. The interpretation of these test results takes longer than just these 21 days. And so what we are doing regularly, we manage the expectations on our MDTs because we already know which type of tumor will take longer, which ones go quicker. And we already advise on the first MDT, at least in our practice, how we do this. We advise the clinical teams that they can release the patient 2 weeks for methylation array, but in 4 weeks for the NGS, if it's for fusions or rare variants. I should perhaps also mention that there are new technologies on the horizon. For example, Oxford Nanopore Technology, ONT, which allows rapid diagnostics on frozen material within 48 hours. And that will comprise all the molecular test components of NGS, fusion tests, and methylation array. So there are methods on the horizon, and they start being implemented on research and kind of evaluation basis in multiple genome laboratory hubs. So there are indeed, there's a perspective that this could change, but technologies need validation. They need the entry on the NHS England test directory, which is the set of instructions what the GLHs have to deliver. So, but this is a continuously moving field, and I would say in 3-4 years' time, we're not talking about these long turnaround times anymore for most of these tumors.
Okay, thank you very much. Just at this stage, could I invite Maria, Ash, and Simon to put your cameras on so that the participants can see you if you would like to do that? Thank you. We're still got a dearth of questions. So one of the things that struck me when you were showing the matrix of diagnostic criteria, there are a huge number of possibilities in there if you go up the columns and down the rows. And what do we do when we get tumours that don't fulfill all of the criteria? Are there major criteria and minor criteria that we can use to help sort these out? Or how do you deal with the ones that don't necessarily go in the pigeonhole?
So let me start with an answer, and perhaps my colleagues have further comments to make. Firstly, we can usually identify within a few minutes looking through the microscope, is it benign or is it malignant? We can also identify very quickly, do we know the tumor or do we don't know the tumor? If we don't know the tumor, many laboratories now take the approach, they start with methylation array, which gives us a catch-all answer for a large number. Not all tumors, sometimes tumors don't classify. And if we see a complicated, expected to be complicated to diagnose tumor, we order straight away on day 2 all these 3 tests. So this is RNA NGS for the fusions, the DNA NGS for variants, and methylation array. In our own practice at our center, methylation arrays come back within 7 or 10 days. But just to manage everyone's expectation, there are many other hubs where it takes about 3 or 4 weeks. But we usually know malignant versus benign. That is still our mainstay, and we can inform the clinicians very quickly after that. We can also tell them when we expect this to take a lot longer, when we have clearly a very unusual morphology.
Okay, so thank you. Federico.
Can I just emphasize the need of attending the MDT? As Sebastian alluded to, we need to be there and mitigate the expectation of the oncologist. We need to consider that before starting the treatment in a high-grade glioma or an aggressive meningioma, it might take 6, 8, 9 weeks because they need the wound to heal, the patient to be fit enough to receive treatment. And being on the MDT and having a proper interaction with the clinician helps decide what test to prioritize.
Sorry, Federico is frozen just momentarily. Sorry, Federico, you just froze there just towards the end of what you were saying. If you could repeat that, please.
I was saying the time between, usually between the first preliminary report, pathology report, and the start of treatment may be 6, 7, 8 weeks because they need the patient to be fit. And that is the time we usually receive the whole molecular panel back. Being in MDT helps discussing with the clinician what to prioritize and then giving, as Sebastian said, an indication of potential aggressive behavior. It's not that we need things done at the same time with immunohistochemistry. We can delay slightly.
Yeah, thank you. So what you're really suggesting then is that we have a stratified investigation protocol, starting with keeping it simple on the H&E and then moving it down through where we think it should go according to that. Yeah, okay. We still don't have any questions coming in. And you have to remember that I'm not a neuropathologist, so the questions that I'm asking may not be the ones you want to hear. So please do come along and ask these people questions because they've signed up to do this. And whilst we're grateful to them for coming, we do want them to work for their money, as it were. So please come with some questions. In the meantime, I guess we were talking about the need for molecular investigation. There are inevitably financial consequences for trying to work within budgets, but at the same time provide what we know are the best possible outcomes for patients. So how do we cope with this dilemma about investigating more, spending more to get what stage do the rewards become diminishing, as it were, in terms of the expenditure with the outcomes for the patients?
Let me try at least a kind of high-level answer, and perhaps I would like then to prepare Simon to comment on a few aspects as well. So let me talk about the financial situations of the genome laboratory hubs. So NHS England, this is now specifically England, which is different in the developed nations. NHS England funds the genome laboratory hubs. The Genomic Medicine Service instructs genomic laboratory hubs what to do and what tests can be done and which tests can be reimbursed or are part of the funding envelope. When the genome laboratory hubs were set up in the late 2010s, so 2018-19, that's when everything was planned and started. obviously the extent and the range of molecular tests was way below what it currently is. And the test directory defines very clearly which diagnoses require or can have which tests. Doesn't mean we have to perform all the tests, but it is now clear that the test volume has, I wouldn't say exponentially, but massively risen over the last 5 years. Now, NHS England has now capped the funding and has instructed the genome laboratory hubs to work within the funding envelope. And in fact, not only that, over the next year, financial year, it's going to be a 15% cut. Plus, and that is a well-known discussion regarding the financials, NHS England will fund only, and they propose 60% of the expenditure. The genome laboratory hubs have to work with this within this funding envelope. That is then countered with different problems in that licensing fee come in place. For example, the Cosmic database costs to the tune of £30,000 unexpectedly. There are now talks about introducing because the algorithm that does the tumor evaluation from a methylation array has been privatized, is now a limited company, and they want to charge over between £100 and £200 per test just for running the algorithm. And that doesn't include the arrays. And all these demands have to be, these financial demands have to be met within the existing budget. So they're major challenges in the delivery of the genomic testing, which means we as pathologists have to be particularly judicious when applying and when requesting tests. And in our MDTs, I always discuss with the clinicians. They say, oh, we want everything sequenced and this and this and that. Can you do fusions for this and that? Then we have to be quite firm and respond the way they say, look, there's no evidence base that this type of tumor ever has shown a fusion, so I don't advise doing it, and we expect that there's no outcome. So therefore, this is an important role for the clinical pathologist to advise the MDT to kind of find the sweet spot between the necessary tests and the nice-to-have tests. And perhaps I stop here now, and Simon, perhaps you have a few comments.
Yes, thank you. And I think everybody would admit that this is a very challenging issue. It's a particularly challenging time, and things seem to be getting even harder. I think the one thing I would say is that everybody's looking at their own pot of money in these things, but actually the key is to get the right diagnosis right and as quickly as possible, because overall, not only is that better for the patient, but that's cheaper as well. And I think, what is the optimum level of molecular testing? I think Sebastian's described it perfectly, is to get the diagnosis right and be pretty rational in the further tests that you do. Often at MDT, you will be presented with a long list of things, and in an ideal world that would be wonderful, but when it's down to fractions of a percent or just a handful of percent of patients who are likely to benefit from that testing, then I think we need to think again in the current climate.
Thank you very much. There are a couple of questions coming in now, which is good, so keep it up, participants, please. The first one is about grade 1 meningiomas, and the question is, should we be testing such tumours for molecular alterations like TERT and CDK, N2A and N2B? That was the question that came in around that one.
There's a really good question and highly relevant, because it's exactly one of those topics that are being discussed. So we have just, it's in revision. It's should hopefully be published in a few weeks' time, a publication where we systematically looked at the value of methylation profiling in a large number of meningiomas. Firstly, we find that particularly the grade 2 meningiomas, the histological grade 2 meningiomas benefit most, because that determines whether they're actually low grade, high grade. Tumors that are grade 1, in our experience, never have a CDKN2AB deletion. A meningioma with CDKN2AB deletion always looks malignant. With regard to the TERT, that's a really useful question. There are publications out there that show a limited value of TERT promoter mutation testing generally, because much of it can be already established with the methylation class and the integrated risk stratification, which integrates WHO grade, methylation class, and copy number profile. The TERT often doesn't add much to this, according to that publication. And we have never seen a TERT mutation in a low grade appearing, so grade 1 meningioma. So the looks of a meningioma give you a very good prediction as to what to expect histologically, molecularly. Rarely there are massive surprises. Peter, you are on mute.
Thank you. The next question that we have in is around about how you report without immunocytochemistry. So the question is focused around pituitary tumours, and what do you do when you don't have immunocytochemistry to fall back on?
Good question. The classic histotypes, somatotroph, corticotroph, particularly have a distinct morphology. So based on the hematoxin using and with integration with the clinical phenotype, you may say this is somatotroph pituitary tumor, PITNET, densely granulated because they are pink, etc. But it's a bit risky. To be safe, at least a minimum level of immunohistochemistry with the 4-5 pituitary hormones is necessary. KSC7 is relevant, but if mitotic count is high, that may be enough. So it's not 100% necessary, but reporting without immunohistochemistry is challenging, very challenging.
Yeah, I think particularly now, it's certainly in the UK, and we really have to, we rely so much on ancillary tests in making firm diagnoses, don't we?
Yeah, absolutely.
Yeah. So I think we're still waiting more questions, but while we're waiting for that, there's a question that came out in my mind. You were talking about those new machines, Sebastian, that allow you to do basically on-site molecular testing, as it were, without referring them on. I mean, it's one of the questions that comes up regularly in these webinars is about the control of molecular pathology testing and how histopathologists have had to cede the control of that to genetics labs. Do you think the opportunity for having really small kit that we can use in the lab immediately will help restore that balance?
I would like to pass the question to Simon. He has spearheaded such a technology and he can report on that.
Yes, I agree entirely that yeah, we're essentially using molecular tests to answer traditionally cell path questions, and that integration, that sort of boundary between cell path and genomics is undoubtedly going to become increasingly blurred. And I sort of sometimes think of it a bit like years ago, the IT department would have run everything that was vaguely IT related, whereas now we do that as part of our daily jobs, and it's all supported by them, of course, and they run the infrastructure and the governance of it. But it's done everywhere, and I think that's how genomics is going to go, not just in cell path, but micro and everything else. And the platform that Sebastian mentioned, the nanopore sequencers really do offer an opportunity to do that. The other thing I was going to say on costings is, of course, if you were to have that sort of solution that gives you all of your data within 24, 48 hours, then you're going to save money all over the place in terms of immunohistochemistry, MDT time, patients not waiting in the wrong bed, for example, because you've got that diagnosis. And of course, getting the diagnosis right is far cheaper, of course, too.
I think we tend to underestimate the waiting time for patients, don't we? Well, I think we have come to the end of our time, I'm afraid, and we've no more time for this discussion. But I'd just like to point out to everybody that there will be a recording of this webinar available on the college website in the next few days. once we've had time to edit it and tidy it up. So that's available to all members and fellows. So please tell your friends, use it, review it, and give us your opinion, because we'll be sending around a questionnaire, just a short one, asking you to provide some feedback for how you felt this webinar has gone. So I'd just like to finally thank all the authors, Sebastian, Federico particularly, but Maria, Ash and Simon too, for all the work that's gone into the creation and delivery of these guidelines. They form an absolutely vital part of what the college does. They're very highly valued by the members, and it's wonderful to see a large team being able to join together to provide us with some sustainability going forward about how we continue to deliver these guidelines. So thank you for all the work and for all the thinking that's gone in behind the production of this webinar, as well as for the delivery today. I would just like to point out finally to participants that there is another of these webinars coming up quite soon. Date not exactly finalised yet when it'll be. Beginning of May, we think, will be the next one. So in the meantime, keep an eye open for these webinars coming up. Thank you all for your participation. Thanks to the team at the college for facilitating. Have a good day.